And first, I'm going to give you a short comment. Coronavirus infection is going around all over the world. And how are you feeling? And this is a tough situation, but I hope things get better soon. And I hope you will take care of your health. So just briefly before my presentation, I'd like to thank Labial Den Company for inviting me to this beautiful webinar and for giving me the opportunity to be able to speak to you today, entitled Suction Effective Mandibular Complete Denture Combined with Bio-functional Prosthetic System. So I hope you will find my presentation to be informative. So let's begin my presentation. This is my first question to you. What other complaints patients have? It goes without saying that the worst denture situation is the maxillary denture that drops down immediately when the patients open their mouth. This failure would be involved with the maxillary denture that is lying on the flattened tissue or flattened ridge, a flabby tissue, accompanied with advanced bone atrophy. The second worst denture is the mandibular denture that lifts up easily when the patients open their mouth. Please take a look at her mouth, the lower denture. She tried to open her mouth wider, however, she couldn't do that because her lower denture easily lifts up. We frequently see the same problem around the world, and this video shows you how difficult it is to learn the skill to achieve mandibular suction. In order to overcome this problem, I developed suction mechanism concept and the technology in 1999. So unfortunately, Japanese publishing companies were associated with the English book sale. So my first English book was published in 2012. After that, I received many inquiries. Dr. Abe, how do you fabricate case denture in class 2 or class 3? So I decided to publish second book. So Mandibular Suction Denture, the Professional, in last year, sorry. So anyway, what is suction? This is suction. As you can see, suction denture is superior than the conventional denture. We are all taught in the dental school regarding retention. No vacuum pads, no denture adhesive, no audio effects, no audible effects. It's true story. So after publishing my book, English book, I started to create many instructors around the world. And there are now 39 clinical instructors and 90 technical instructors in the world. And I'd like to thank all of the instructors to spread out my denture technique around the world. So I'd like to introduce my instructors. The top left, Paul McNally and John Weavery and Carl Fenwick and Chris Ingham in England. And Frank Zimmerlin and Matthew Boxhorn in Liechtenstein, who work for Labial Den head office. And in China, Dr. Cho, Ma, and Dr. Sun, and also Dr. Kwanto Eno in Korea. He's the only one clinical instructor. And Jonathan Sen in Taiwan, and Andrew and Kelvin in Singapore. And the bottom one, Team Australia, Robert Mattison and David Smith, Shane Chambers, Peter Anastasia, and John Batchelor from New Zealand, and Stephen McLean, and Hiro Uchida, and Annie Jabor. And finally, I'd like to introduce Team Canada, Marcus Fisher, and Esther, and Erica Colbank, and Stephanie, and finally, Eric Kukuchika. So if you need to learn suction effective mandibular denture, don't hesitate to contact them immediately. They are very kind. So there are many different types of lecture and hands-on. The left one is a big conference that have seating capacity of 2,000, very huge. And on your right, maybe 30 or 40 participants in the small group demonstration course. So I showed them my technique with a live patient. But face-to-face, the SEMCD hands-on basic course is highly recommended to you. So because you can learn not only suction effective mandibular denture technique, clinical technique, and the laboratory technique. So Sandra and Nancy used to be work for Ivoclar Vivadent as an instructor for a long time. And I met them in Toronto last 2 years ago, and they decided to come to Japan to learn my denture technique. And instructor course is very severe. So Carl Pembeck is now training at my office, and of course under my supervision. So anyway, if you need more information and if you want to improve your clinical skill with suction, please contact instructors immediately. So my webinar is separated into three days. On day one, today, I'd like to highlight the suction mechanism of the Mandibular Complete denture. And on day two, I'd like to highlight intraoral examination, and I will show you, or I will teach you how to fabricate well-fit custom tray to be able to achieve mandibular suction. Very important part. And on the day three, I will report to you so easy and a difficult case with analog and the digital technology. So first, I'd like to verify beneficial advantage with SEMCD. So this patient wore a good suction denture, and I'd like to show you X-ray TV images. This is the actual record, and a patient is eating hard dumpling with volume. And so that we can clearly see the movement of condylar, smooth movement of condylar, and the beautiful mastication. And finally, we can see swallowing. Nice. And the next frontal view. So first, unilateral occlusion is established, and gradually it's changed to bilateral balanced occlusion. As you can see, a lower denture doesn't move enough. This patient had one aging problem because she couldn't swallow food at once because food is left on the laryngeal part. And yeah, can you see here? So, and she swallowed food with the second. It's an aging problem. So it caused a choking or so aspiration. To make it more clear, to make it clearer, take a look at. So these are interpolation points, and the two green dots are benchmarks. And the movement of blue dots are measured from benchmarks. And as you can see, so the lower denture movement is tightly coordinated with lower jaw movement. On the other hand, upper jaw movement is mainly in response to forces applied on it by the chewing motion of lower denture. It's very important. I emphasize that suction denture have a major effect to reduce the denture mobility during function. So another advantage of SEMCD is impression technique is doable, very, very doable impression technique. So this is a university, this is a dental school, and she was a young postgraduate dentist. And other elder dentists actually made a fool of her because she was very young And so you cannot achieve mandibular suction because suction denture is very difficult for everyone. But take a look at very nice. And this sound changed their denture life. Denture life. Yeah, it's a game changer. And Esther is a very now popular in Canada. And she's a BPS suction and the digital instructor. Nice catch. Yeah. So the goosebump. Very nice. Yeah. The goosebump feel when you can hear the popping sound. So, and one more question to you. So, how do you evaluate or estimate if your impression is successful or failure? For example, if you fabricate upper denture, when you fabricate upper denture and the upper denture easily drops down, oh, of course, it's failure. But lower denture, how did you estimate if your impression is good or not? So we are all taught in the dental school, of course, compound impression technique. And patients wearing lower denture without implants were considered as a dental handicap in the past. So if once you get enough suction when taking impression, I think you can easily estimate if your impression is very, very successful. So suction, popping sound is very important and to change your life. In truth, success rate of suction denture is approximately 87%, but not 100% because there is no 100% treatment. There is no prosthodontic treatment with 100% success. And the remaining 13% of edentulous patients cannot get enough suction. And some of them need a therapeutic denture to normalize their mandibular jaw position before a final denture fabrication. And some of them need 2 implants to enhance their oral function. And I hesitantly recommend commercially available denture adhesive to patients with dementia or dry mouth. It's a true story. So why are the conventional dentures unable to achieve mandibular suction? These are impressions from the same patient. These are impressions taken from the same patient. And left two impressions, a compound impression technique. So we are all taught in the dental school. And conventional impression is oriented to take muscle attachment in order to design a denture. So target of conventional denture is muscle attachments. It's very important. And the purpose of the conventional denture is to achieve better masticatory performance through enlargement, through extensive enlargement of denture bearing zone. So denture must be bigger than the normal one, typical one. On the contrary, the purpose of suction denture is very different. So to seal the entire denture border with oral mucous membrane. So the target of the suction denture is oral mucous membrane, but not muscle, because we cannot see muscle directly with our eyes intraorally. The left denture is fabricated according to the conventional type, and the right one is a suction denture. So I think you must have thought that suction denture would be larger than the conventional one, but the fact is contrary, smaller than the conventional denture. Why is it, what is absolutely required? So for complete denture suction, my answer is crystal clear. Very simple concept, complete sealing of the denture border. So here is a denture here, upper denture here. So if I make a hole on the palate region with a bar, then actually denture easily drops. Of course, because Dr. Abe made a air leaking spot on the palate region. Yeah, sure. So lower denture is identical. So regardless of whether it's a maxillary denture or mandibular denture, there is no instance where air breaks the seal. If the seal is not perfect in even one place, the maxillary denture will drop down and the lower denture will lift up. It's clear even to a child. So this is the principle of suction, regardless of whether it's a maxilla or mandibular. Why is it difficult to create a suction denture in the mandible? So I think there are three reasons. First one is the smaller, so mandibular ridge is very smaller than that of maxilla. And the second one is the tongue is located in the mandible. So tongue retracts or tongue moves up and forward and side to side. Air leaking spot is created around the sublingual region. So the final one, the third, it's not known for a long time in the past. The movable volume of mandibular mucobuccal fold is 2 or 3 times greater than that of maxilla. So I'd like to show you a precise animated movie reproduced from X-ray TV that is created in 1975. And as you can see, upper, so mucobuccal fold doesn't move enough, but take a look at the lower mucobuccal fold. So moving a lot rather than the upper mucobuccal fold. So I want to say that upper dent impression is very easy for a beginner, but the lower denture impression is very, very difficult for everyone because mucobuccal fold and lingual mucobuccal fold moving a lot. This is my study with MRI. On your right, red part is the vaccinated muscle, and yellow part is the submucosal tissue. You may notice that all of the denture border comes in contact with surface of oral mucous membrane, but not muscle. So the main player of the denture seal is the oral mucous membrane, but not muscle. On the contrary, the main player of the muscle activity is muscle. Please separate the two things. Why do I recommend BPS? Why did I select BPS from among many ways? Honestly speaking, I have been a GC instructor, monitor instructor for a long time because suction effective mandibular complete denture is just a concept, but not a system. So SEMCD can be applicable for all companies' products. So GC monitor, okay, no problem. We will get enough. We'll make a suction effective mandibular complete denture when using any company's materials. But, very important. BPS is a shortcut way to improve your suction denture skill levels. It's very important. So I'd like to answer referencing this article. So Dr. Fenlon concluded that the most important aspect to satisfy patient is to obtain the accurate reproduction of jaw-to-jaw relationship. In short, bite registration is the most important requirement to satisfy patient. Of course, it's known for a long time in the complete denture therapy, adaptive capacity of patients and the effects of patient's personality and also patient's, human relationship between patient and the dentist are on patient rating of suction, patient rating of denture satisfaction. The second requirement was lower denture stability. So suction denture just match with this requirement. By the way, what is the best denture fabrication system to agree with first requirement? I firmly believe that is Bio-functional Prosthetic System from Buccal Dent, because BPS has unique 3-step procedures of determining mandibular jaw position. So in the first phase, primary bite record is taken using centric tray. Very nice. But this is not a precise byte record, just a temporary byte record or almost byte record. And after fabrication of the custom trays, final impressions of after fabrication of the custom tray, and the impression has been precision impression has been finished. Next, following precision impression, we needed to check if particular dimension is correct or adequate or not, using a phonetic method or freeway space. So patient is now counting backward from 70 to 6. I'm sorry, Japanese language. But this method forces the patient to concentrate on just counting. And the patient easily forget to be observed by the operator. We always watch out for 3 millimeter space during speaking. Very important. And after change the vertical dimension, we'll move on to the determine the horizontal mandibular jaw position. So Nasomera M is very nice, and also final precision suction impression will become a nice tray, nice Gosek arch base. Yeah, very nice. No moves, and very stable. And then tap, and then move your jaw forward, backward, tap. Okay. So let's move on to the suction mechanism of the mandibular complete denture. It's the main topics. Lower suction mechanism is comprised of 5 different types of closures, a little bit complicated. So first, I'd like to talk about the labial and buccal region. So indicated by blue arrows. The exterior surface of the denture base, denture border, comes in contact with lip tissue on your left side at the incisor area, and the buccal mucosa in the molar area. And the interior side of the denture base, indicated by the green arrows, comes in contact with lip mucosa and in the incisor area, and the ridge mucosa in the buccal molar area. So it's a very, very strong closure like a sandwich. I named it labial buccal interior exterior double closure. Very, very strong closure. In order to enhance the denture bearing zone, when fabricating custom tray, please with the thickness of the buccal shelf region, so final denture as well. And if you find if you encourage the patient with a shallow labial vestibule, the thickness should be given to the anterior part, labial part. So they are very famous and actor and actress from Korea, and they have a beautiful dent here, dent. So I think more thickness make it possible to create more beautiful condition similar to this. Okay, let's move on to the ceiling of the lingual area that is separated into 2 types of suction mechanism. Prior to the detailed explanation of this, I'd like to show you a difficult sealing area first. When the mouth opens, tongue retracts slightly, and you can see the space around area around the sublingual region and area around the retromolar pad region indicated by red arrows. So please pay attention to seal the denture border at the 2 areas. Okay, mandibular lingual sealing is separated into the seal at the sublingual fold and the seal at the retromolar fossa region. So the left here is the coronal close section shown as line number 1. So at the sublingual fold, and on your right, bottom right, the close section shown as line number 2 at the retromolar fossa. So I'd like to highlight the seal at the sublingual fold first. Yeah, It's called lingual interior exterior double closure. So at the first sight, you have already found that the ridge is inclined from right to left to right. But please focus on the sublingual spongy tissue that is located behind the anterior ridge, because lingual denture border sinks down at that area. And when the sublingual fold area is rich with spongy tissue, we will expect to achieve mandibular suction. Take a look at the blue part. When the mouth opens, thanks to presence of the sublingual spongy tissue, the seal would not be compromised. Very stable sealing. So there is no exaggeration to say that the magnitude of negative pressure depends upon the amount of sublingual spongy tissue. This is a very beautiful complete sealing of the denture border. So here, as you can see, there is no space at the sublingual lesion. So a denture border, lingual denture border, completely engaged with the sublingual tissue. To reinforce the interior exterior double closure with the sublingual spongy tissue, when fabricating custom tray, the thickness should be given to the sublingual denture border, final denture as well. Very important information. Keep in mind. So here, I'd like to show you precision impression technique in straightforward case. This patient has a very nice ridge, good ridge form, and a stable mandibular jaw position. And I usually ask the patient to make 5 exercises. Tighten the lips, sound E, and move the tongue across the upper lip to capture the tongue movement, back side of the tongue movement, and push the back side of the anterior bite rims with the tongue. Then the lingual floor raises up, lingual floor becomes stiff. Then we can easily capture the lingual floor movement, and finally swallow. So 5 movement is 1 cycle, and ask the patient to make this movement maybe 2 or 3 times, depending on the impression material setting time. In summer, so impression material setting time is very shorter. So upper impression has been finished, and I place it back to the mouth. Lower impression. Now we'll start. Light bodied impression material is applied. And I ask the patient 5 exercises. Ooh, ee, 2 movements. And I hold that tray down. And ask the patient to move her tongue side to side and stick out the tongue and lock the chin and push the backside with the bite rims with her tongue, and then finally swallow. So you may notice that this impression technique is a patient-centered impression technique, but not operator-manipulated impression technique. So if you fabricate, once you fabricate well-fit custom tray, you will, and you will take a same impression in same side and in same shape. Unfortunately, we sometimes encounter the patient without sublingual spongy tissue, flat sublingual spongy tissue. It's called the tent-like tissue. So if that happens, we will find that in that case, in my daily practices, we want to be able to achieve mandibular suction, because seating area is extremely small, then when the tongue moves, the air leaking spot will be created at the sublingual denture border. Okay, next, can you notice another problem when taking a look at this picture? Tongue retraction. So in 75% of edentulous patients, tongue retracts slightly within 2 centimeters in general. In type 1, tongue retracts more farther, so maybe from 2 centimeters to 4 centimeters from the anterior ridge, and even further in type 2. Very difficult case. So on your right, air leaking spot is completely created at the sublingual denture border. So it's incomplete, it's ineffective, suction ineffective. Let's move on to the compensatory closure at the retromylohyoid fossa region. So indicated by the green arrows. Yeah. So please take a look at the light picture. And okay. Oh, sorry. I'm sorry. Rewind. Okay. So as you can see, the space is created under a lingual denture border, under the lingual denture border. So it's it's not a perfect closure. It's called compensatory closure that is attained with the tongue side wall, applying pressure toward the denture underneath. So the 2 to 3 millimeter extension of the denture border is mandatory to create the resistance wall. Light figure shows you adequate extension of the resistance wall. The contrary, on your right, so denture border doesn't reach to the mylohyoid line, so the denture easily slides away by the tongue pressure. To complete the compensatory closure at the retromylohyoid fossa region, thickness should be given to the retromylohyoid fossa region and the final denture as well. So be sure that thickness should be given to the sublingual region, and the thinness should be given to the retromylohyoid fossa region. It's very important. Please keep in mind. But there are 2 criticisms to expand the denture border over the mylohyoid line. So from anatomical field and physiologic field. So Dr. Nagel reported that denture, so tray border should not be overexpand beyond the mylohyoid line, because it's interrupt the muscle activity. But from the current of anatomical point of view, so analogist report that the denture border can be extended over the mylohyoid line because the muscle fiber, please take a look at on your right, muscle fiber runs in the inferior direction at the maximum contraction. Another criticism is from physiologic field. So they insist that the retromylohyoid fossa space is a natural or original space in the healthy dentate, but not created after becoming edentulous. So denture border shouldn't be extended over the mylohyoid line because the natural original space will be interrupted. I think this opinion is, almost correct. Yeah, completely correct. I agree with this opinion. However, this is upper denture, once again. Do you cover do you cover the upper palatal region with a denture base when you fabricate a maxillary denture? Everyone said yes, because it prevents the maxillary denture from being dislodged. Why, Dr. Abe? Why do I extend the denture border over the monohyoid line? I want to seal entire denture border with oral mucous membrane. So it's considered as a necessary evil. Let's move on to the close contact closure with the, let's move on to the closure, suction mechanism of the retromolar pad region. So it's separated into two different types of closures: close contact closure and exterior closure over the denture base by the you have to do closure over the denture base. Okay. And first, I'd like to highlight close contact closure first. So the interior surface of the denture base comes in contact with the retromolar pad tissue intimately, as it's identical to the maxillary palatal ceiling areas, maxillary palatal ceiling. But this picture is an ideal situation. Just I cut the model. Yeah. So you are aware that retromolar pads are easily deformable by impression pressure and the mouth opening closing movement. So now this is the retromolar pad, and the retromolar pad is plump and short in its closed mouth, and the mouth is opening. Retromolar pad is stretched out and flattened. So let me pose your question. What should the impression of the retromolar pad region be taken? In which shape or status should the retromolar pad be in when taking preliminary or precision impression? My answer is crystal clear. The target shape of the retromolar pad in the preliminary impression and the precision impression stages we want is the natural shape of the retromolar pad. So closed mouth impression technique is highly recommended for you, because a negative pressure will be built upon in the interior side of the denture the moment denture subsides down to the alveolar ridge. So closed mouth impression is very important. To overcome this problem, this is the frame cut back tray. It's a major effect to reduce the deformation of the retromolar pad. And thanks to this frame cutback tray, we will take a static impression in its closed mouth, because frame on the retromolar pad and buccal shelf region is removed, and the easy biting handle allow the patient to take a closed mouth impression, and tongue space is very important. So I firmly believe that the preliminary impression using frame cutback tray is the first step to complete the mandibular suction denture. I'd like to show you the preliminary impression technique. So light body alginate impression material is squatted from retromolar pad to retromolar pad, and go around and go back to the starting point. If you find the space on space, so please add the impression material on that space. And a frame cutback tray molded with heavy-bodied alginate impression material is inserted into the mouth, and then press it down. Be sure not to rotate the tray down posteriorly, and straight down. And after stick out the tongue and relax for 7 seconds. After that, change your finger position and relax and pull up lips with the operator's thumb, and finally massage. This motion prevents the building up of the impression material within the cheeks. Suction. So this patient is very severe. So, but you can see the beautiful posterior end of retromolar pad can be seen. the surface of the impression is a little bit wrinkle, but it's okay. It's a natural shape of intraorally. Why should the retromolar pad be taken with a closed mouth? You have already learned the shape in its closed mouth is very different from the one in its open mouth. If you fabricate lower denture in its closed mouth impression technique, according to the closed mouth impression technique, dentures are fabricated and inserted into the mouth. So, and a mouth try to open, then the denture base covering on the retromolar pad region control the deformation of the retromolar pad region. Because there are two reasons. The posterior end, distal end of the retromolar pad is not fibrous tissue, it's a flabby tissue. And also, there are many muscles attached around the retromolar pad, but there are no muscle attached there directly. No muscle attached to retromolar pad region directly. So this is a reason full coverage or almost coverage of the denture base control the deformation of the retromolar pad region. And if you fabricate the lower denture according to the open mouth technique, do you remember compound impression material? Mouth, please open your mouth and operate a full cheek, and yeah. How much of the compound impression material should be softened, and how strongly should the operator pull the buccal mucosa or cheek mucosa, buccal mucosa or lip mucosa? So it's very difficult. It's technical sensitive, I think. So when I was young, I tried to take impression using compound technique several times, but it was very difficult for me. Yeah. So I changed my mindset from operator manipulated impression technique to patient-centered impression technique. So dentures are fabricated according to the conventional type and inserted into the mouth on your right. And the mouth has just closed. Then air leaking spot is created. This is a reason. So this is a reason the closed mouth impression technique is highly recommended to you. These are two impressions. Left one is a conventional impression technique with pressure-loaded method. So all tissues are stretched out and open mouth impression technique. On your right, so suction frame cut back tray impression with least pressure-loaded method. The purpose of the frame cut back tray impression technique is not to deform, not to reduce, not to minimize the deformation of the retromolar pad region. So the size of retromolar pad is very, very different. I conducted a study to compare 3 different impressions of a bilateral free-ended situation taken with a stock tray and a frame cutback tray in regard to the distortion of impression. The first impression was taken on your left using a stock tray with single arginate material. And the second impression was taken using a stock tray with 2 different consistency of arginate impression material. Pink is light-bodied and the white is heavy-bodied. And the next one, the third impression was taken using modified frame cutback tray with 2 different arginate impression material. So 3 data are superimposed. And this is a picture of 3 layers. And I take a look at the cross section at the retromolar pad region. Okay, cut. And this is the cross section of the retromolar pad at the retromolar pad region. As you can see on your right, so 1, 2, first impression, second impression, push the buccal mucosa far out to the buccal. But the third impression didn't do that. So the The biggest risk factor to distort the retromolar pad region is the presence of the frame. So this is the reason I developed the frame cutback tray. So let's move on to the final suction mechanism of the posterior end seal around the retromolar pad. Two different types of closures, cross-contact closure with the interior side of the denture base and the retromolar pad tissue, and the entire closure denture base. Entire closure over the denture base by the cross contact with the tongue side wall and the buccal mucosa. So it's called BTC point, but the buccal mucosa hanging over the retromolar pad tissue, and the tongue side wall compressed at the lingual polished surface, and the BTC point is formed. The denture is inserted into the mouth, and the mouth is closing slowly, and the mouth has just closed. Then BTC point appears, regardless of whether healthy dented people, children, and edentulous people, or BTC point appears. So I think it's considered as an essential physiologic feature. I conducted a study to observe the variety of retromolar pad region. So duplicated denture was modified with endoscopic camera. So now the left is the tongue and the right is the buccal mucosa. And as you can see, the well-fit denture base can be seen even though it's a duplicated denture because I fabricated it. So BTC point appears on the retromolar pad region in its closed mouth, and the mouth is opening slowly, then BTC point disappears. So the main sealing of the around the retromolar pad region is a close contact closure. Interior side of the denture base comes in contact with the retromolar pad tissue. This is a main suction mechanism, sealing mechanism. And secondary, BTC point, the formation of BTC point ensure the building up of negative pressure when swallowing or when chewing. So this is my study with MRI. So I want to show you the coronal close section of premolars and molars and retromolar pads, but due to the time limitation, I go through it quickly. Okay, this is the retromolar pad region. Okay, can you see BTC point can be seen? And this is the actual record. Red part is the vaccinator muscle, and the yellow part is the fatty tissue. And the red point is the BTC point. As you can see, you have already noticed that the BTC point is created with oral mucous membrane and tongue side wall. So do you remember what I said? What I stated before? The main player of the denture seal is the oral mucous membrane, but not muscle. The main player of function is, of course, muscle. Please separate two things. Oh, sorry. So red part is the vaccinator muscle, and the yellow part is the fatty tissue, and the red part is the denture, and the red point, or blue part is the denture, and the red point, it depicts BTC point. So I conducted a study to create the overexpansion situation. The lead wax is molded, excess lead wax is molded on the buccal side. Then mouth is closed. Mouth is closing, but overextension of the lead wax interrupt the buccal mucosa covering on the retromolar pad region. So BTC point didn't didn't appear. This is the same finding with MRI. So space is created on your right. So incomplete BTC point. And so next, lead wax is molded. So it's overextended denture borders to the sublingual lesion. Yeah. And the mouth is closing slowly, but the BTC point didn't appear because overextension of the lingual denture border affect the tongue movement. So, in order to create the beautiful BTC point, please draw the line between the cheek mucosa and the ridge mucosa. Be sure not to overdraw the line on the cheek mucosa. If you do that, the mandibular denture would lift up against the opening reaction of the mucosal tissue. So what's the meaning of the formation of BTC point? If the BTC points are not formed, please check if buccal shaped denture border is overexpanded, or so the lingual denture border is overextended, or tooth position is correct or not. Tooth position is usually tooth are aligned usually in the middle of the width, ridge width, and of course pound line is very effective. Pound line is very effective. So to create the BTC point, denture border. So this is a custom tray, and the denture border becomes very thin, and the denture border denture border. Sorry, tired. Sorry, water. So, denture border on the retromolar part region should be covered thinly and avoid the sinuous ring. What is the sinuous ring? I will talk about the sinuous ring after that. And buccal shelf, the concavity should be given to the buccal shelf region, and concavity is created in the tongue root area, and finally, full coverage of the retromolar part region of with the denture base. It's very important. So please keep in mind. Okay. So what is sinus ring? Sinus ring is located at the buccal base of retromolar pad region. It's a small frenum, but please avoid frenum, avoid sinus ring, regardless of whether it's visible or invisible. So appearance rate of sinus ring is only 13%, but when the operator pulls the buccal mucosa outward, the appearance rate is going up to 40%. So measuring experiment to pull the suction denture base is conducted to study how much of the retromolar pad should be covered with the denture base in order to obtain good suction action. So the denture base, suction denture base is created first, and the operator pull the suction denture base by the dental force gauge. And the denture border is trimmed off posterior to third, middle, and front. This is the outcome of this experiment. So in order to get enough suction, so you two to three of the retromolar pad should be covered. But in my training course or seminar, I always teach course participants full coverage is much better because it's easy to trim off when delivering lower dentures. Okay. Okay, this is the principle of suction dentures. So thank you so much today. And due to the time limitation, I cannot talk about the suction mechanism very well, but I hope you found my presentation to be informative and impressive. So next time, I'd like to highlight intraoral examination, and I will show you how to fabricate well-fit custom tray with 7 ideas. So thank you for attention.